giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence in management of NICU babies. Just having fun with it. All right, hello everybody. So I wanted to do this live because, well, next week is NICU Nurses Week. So definitely wanted to talk a little bit about kind of, some of the things that physicians can do to sort of teach, and the relationship that we have with nurses, so on and so forth. So there's a few topics that I wanted to touch on today in this live, including just talk a little bit about communication. And I think communication is so key between just any member in the medical team, but obviously between the physician and the nurse. The nurses are right at the bedside, pretty much all day, 12 hours, 15 hours, 8 hours, whatever it is that you do. And we are there at the bedside pretty much mostly for rounding and honestly for any kind of disasters or any issues that are happening with the babies, or if you call us to the bedside. But you guys as nurses and PAs are really very much involved and right there at the front line, if you will, of caring for the baby. So communication is absolutely key, and that's the topic for today. I just really wanted to talk about a few things in communication. So we're going to be talking about SBAR, situation, background, assessment, and recommendation. Okay, most of you guys have probably heard this term before, but I'll sort of break it down and give some examples of how we can actually use that when you're talking with a physician. Specifically on talking with a physician, we are going to be talking a little bit about how the nurses can feel more included on rounds. I think sometimes you have the culture is such that it's the physician talking to everybody else, and you might not really get a whole lot of a say on rounds. And so how do we help the nurses be much more engaged and really be involved on rounds? So we'll talk a little bit about that. The other thing is calling a physician. So if you're taking a night call during the day, but specifically you're taking a night call or you're doing a night shift and you call the physician at 3 o'clock in the morning, what are some of the things that, it's never an easy call either way, by the way. So what are some of the things, some of the tricks that you can do? And also, again, communication and transparency. I'll tell you some of the tricks and some of the things that we do as physicians to help us on that 3 a.m. call. Because again, most of the time, you may be taking a nap, maybe sleeping, you're woken up. Usually it's because there's something going on. So we'll talk a little bit about how do we, some of the tricks that we use. Then I'll sort of mention some of the things that we as physicians, and again, this is my opinion, but I can speak for some of the things that I think can really facilitate communication between the nurses and the physicians. So some of the things that I, in general, prefer not to hear from the nurse. And again, this is not going to be a negative point of view. On the contrary, it's going to be actually something positive as to some of the things that we can actually learn from each other. I will sort of give a few examples of difficult situations and difficult scenarios, honestly difficult physicians, and how could you as a nurse be able to, or a PA be able to approach the difficult physician, if you will, and we'll go through a few examples of those. So, having said that, let's go ahead and get started then. So, SBAR. This is basically, again, the mnemonic of situation, background, assessment, and recommendation. And it's a way to be able to communicate, not only, this is not just, by the way, a nursing physician thing, it's just a way to be able to communicate between different staff. And we use it also between different physicians as well. So when you're talking about situation, you really want to give a little bit about why it is that you're communicating this information to somebody else. So we're going to be talking specifically nurses to doctors. So in a situation, in a scenario where you have a 25-week baby and you may be having a cluster of desaturations, you really want to, when you call the physician, whether it's a resident fellow or an attending, or a nurse practitioner, you really want to be able to start with situation. This is so-and-so. I'm calling because I have a baby so-and-so who's in room, whatever, 12. And I've been noticing that really in the last hour, we're having a lot of apneas, a lot of Brady's. There's something going on. I'm a little bit concerned. Then this leads to the second part of the SBAR, which is your background. In your background, you're going to be talking now about, you gave the situation, now what's the background, a quick one-liner, if you will, on the patient. I had this situation. Just to give you a quick background, this 25-weeker actually was born 2 weeks ago, developed within the first 3 days a spontaneous perforation, is currently NPO, had to have a drain placed last week, and had been doing real fine until today. So just a quick situation, a quick background, just so we know, in general, we have a pretty good idea who the patients are. But again, a quick kind of reminder of who the patient is in their background. And you don't need to go ahead and give a whole historical, we're not signing out your patient and give a whole lot of information. Basically, you just need to kind of let us know a quick, especially the background that's really apropos, the background that's really important for the situation that you're communicating for. Then you get to the assessment. And this is really important and very key. When you have talked about what's the situation, what is the background, that's where you really come in. The assessment and recommendation are so important. And again, nurses, PAs, very smart people. You've gotten there because you've gone through all this, schooling and all the tests and so on and so forth. You're really smart. You're able to really assess the patient. And that's where you bring in that to the communication. This is a situation, this is a background. I went and examined the baby, noticed that the abdomen is distended again, or is distended. There's a bluish discoloration, blackish discoloration on the left side. The baby's vitals are, blood pressure is a little bit soft. The systolics have been dropping a little bit in the last couple of hours. And I think perfusion may be down as well. The capillary refill in the lower extremities is 5 seconds. So again, now you've given your situation, a little bit about the baby background, and now what is your assessment is sort of the big picture, what's going on with the baby. And that's where you bring in the final part, which is what is your recommendation. A lot of the nurses and PAs and trainees, they stop at SBAR. They forget the recommendation. And we as physicians, we really want to know what you think and what you think we should do next. And it's really important. I mentioned it already. You guys are really smart. So it's actually expected for you to give us a recommendation of what you think we should do. I've got this situation, I've got this background, I examined, this is my assessment, I'm concerned, that there's some perfusion issue and maybe the baby's going into shock because of sepsis. I would like to, obviously, we are already NPO. I'd like to go ahead and, place a Replogal. I would go ahead and get cultures, start antibiotics, get a KUB, get a gas, get some blood work. We don't need to go into any details on this situation, but essentially, you're giving your recommendation of what you think is going on. And that's the gist of SBAR. It's, again, a way to package the information together so that you are able to put it in a nice little package. And especially when you first, this is going to become very natural, but when you first start out trying to communicate as a resident, as a fellow, as a nurse, or you're talking to somebody else, another physician, you really want to be able to have a mind frame. And so, because we all get a little bit nervous at first, especially if you're calling a consult, if you're a nurse and you're calling in the middle of the night. So you go through that nice, neat little package of going through your situation, your background, your assessment, and your recommendation, and it will become very natural. After time, you're not really thinking, okay, what's the situation? What's the background? You're really kind of having the same lingo, the same program. You're doing it very, naturally, with what you have already learned with experience. And after a while, you realize when you're talking to your physician or you're even talking to another nurse, you're already doing SBAR without actually realizing that you're doing SBAR. So that's a really nice way to be able to remember that. And again, it will become natural. All right. So let's talk about the second part, and that is actually talking with physicians and feeling, that you're part of the team. Again, one of the mistakes that happens sometimes is that you are, as a physician, I can tell you honestly, sometimes I'm dealing with extremely sick child. I'm already or baby. I'm really thinking about all the things I should be doing on the middle of rounds. I'll let you in the trick section. I'll talk a little bit about how you are, as a physician, training yourself, especially during residency and fellowship, to think and hypothesize and listen at the same time. And that in itself is difficult. I'll give a shout out to Dr. Michelle, Michelle Hochnicki, who's joining us. She's training to be a neonatologist, and she'll really be able to train her ear and her mind to be able to listen, formulate a hypothesis, and at the same time be able to regurgitate what's going on. It's a skill, and you become way more comfortable in time. So going back to rounds. So one of the things that we need to do better, and we always strive for, is communication. And when it comes to rounds and when it comes to nursing, there are several places, many places will actually have the nurses go ahead and present on rounds. And I think that is an absolutely important thing to do because it really engages a nurse. I think obviously the nurses know the patients really well. They can go through the vitals, they can go through the overnight events, maybe even talk about the labs, and it really shows 100% ownership. And it helps really engage to be part of the medical team when you have the nurses present. If they're not able to present, if that's not something that you guys do within your unit, thank you, Dr. Ashada. Big shout out. Hello. Thank you for joining. So if you're not able to present on rounds, that's okay. You can still be a really engaged and be an important member of the team because you know the patient really well. And obviously, if you're in an academic center, you're going to have the intern, the resident, the fellow. They're going to go through all their presentation. You're going to listen. If you don't have if there isn't an actual structure within your institution where you will jump in, whether it's at the start, middle, or end, and you are just, again, part of the team, that's what really, there's so much input that the nurses and PAs can really give to rounds. Because again, you are at the bedside. I kind of joke all the time, it's like the nurses are the second mamas. You know the babies really well. And so when you're on rounds, important to give a little tidbit about your patient that maybe we haven't acknowledged. So we talked about the vitals, we talked about the labs, and this is where you as a nurse can really, it's really important for you to come in and state something that you really think will affect the decision, the patient care, and you guys are absolute advocates to your patient. And so it's so important for you to be able to speak up and be very comfortable. And that's where we as leaders, as neonatologists, whoever's leading the team, really have to be comfortable and open to allow anybody to completely go ahead and state how they feel, what's going on. And I'll get to sort of how we wrap up rounds at the end, and that's another opportunity for the nurses to come in. But in the middle of the discussions, as the resident fellow, if you're in an academic place, or if the attending is going through the chart, as they're going through that, it's really important for you to go ahead, if there's something that you feel is really important, to speak up and be able to jump in and say, I noticed you mentioned the sodium being a little bit low. Well, you talked about the events overnight. One thing I got from the nurse who signed out was that, A, B, C, and D. And so it's really important because we don't get all the information. We really get a lot of it from our medical sign-outs. We get a lot of it from the chart. And obviously, it's really important for us before we do our rounds to speak with the nurse, especially with those sick babies. But if we don't get that chance, that's the chance to do it. And then at the end of rounds, again, the medical leader should really have a moment where you look around your team and you state, is there anything else we're missing here? Is there anybody else want to mention something else? Are you guys in agreement with the plan? And that is the second step, or a second point, where you as a nurse or a PA, if you don't feel like the plan, that you like the plan, that's where it's important for nurses and PAs to speak up, and for us to allow that environment, to really make sure that you're looking around your team, that they feel comfortable enough that the nurses or anybody else in that team can speak up to say, I understand you want to go ahead and start, this medication. However, I'm a little bit concerned because last time we did that, things didn't go well. And so it's important to be able to have that open environment to communicate, and then for us as leaders to be okay with hearing that, and then use that. If it's something that we feel strongly about, then use that as an educational moment. As clinicians, you can't just say, no, we're going to go ahead and do that. Nobody wins in that case. And we're all there for the patients. And you want to have that open environment always. So if it's something that you feel the physiology really backs up what you're trying to do or what the team has decided, then you really have to, basically push back with education to say, okay, I understand that you have some reluctancy to do this. Let me give you my point of view and the physiology to make sure that, that everybody understands why I would like to do this. And if you still get pushback, and especially if you're getting from multiple members, then we as clinicians and leaders need to stop and say, well, maybe there's something to this. If 2, 3, 4 members feel really uncomfortable with what you're doing, then maybe you need to look in the mirror and say, am I doing the right thing? Am I doing the right thing for the patient? And so that's where, again, we have to be okay if you're hearing it from several people to say stop, and then readdress, pivot. This is something that we have to be very comfortable with. I'm going to look through some of the comments, and I appreciate everybody joining. I know some of these folks, and thank you for joining this live. And Miss Coffee and Katie says, not all NEOs or fellows care about the nurse's input. Amen to that. It is true that, and you're right. Unfortunately, there is still a little bit of the culture where and again, this is where the medical team and the medical leader needs to say that from the get-go. Every time I start a rotation, and again, I think most people know me by now, and I hope and I feel like most people are okay with coming to me with concerns. Doesn't happen all the time. Again, I've been burned before where I thought everything was great and the whole team was super happy, and it ended up not being the case. And that happens, and we learn from that, and I strive to always improve communication. But that's where, again, it's on us as a medical team to be able to allow that environment, to be able to mention that, and for us to train our fellows to say, hey, look, and I do this with all the trainees all the time. I tell them, come in and listen to your nurses, because if a nurse or a PA is calling you and saying, hey, I need you at the bedside, and we'll talk about that. That's one of the tricks that I mentioned, some of those buzzwords that you guys will learn in a minute to really get your medical team engaged. But it is one of those things that if you really, are not really getting listened to, there are tricks to get your medical team to come. And again, we'll talk about that. From our end, we have to be open to if I hear a nurse saying, hey, I need you at the bedside, you have to go. And sometimes it is something that we in our own medical mind, and again, I mentioned this at the start of the live, we're going to be completely transparent. I'm going to just say things as they are sometimes. We may go in and say, seriously, you called me for this? In our mind. Do not ever say that for those that are training. So this is where that's a great opportunity now to educate, to use that moment to say, oh, I understand you're concerned about the fact that we had to put the baby NPO, or we went NPO. Let me explain why we had to go NPO in this case. I know normally we wouldn't do it, it doesn't make sense. I understand your concern. But in this case, this kid has a weird metabolic disorder where we really can't do this and we need a special type of formula. So for now, we're going to go NPO instead of going ad lib. And so again, you use that as a big educational moment. I want to stop and say hi to the people that have joined. Again, we have Nicole Morte, and we have Alicia and Katie. Thank you everybody for being on. And again, if you guys, by the way, if anybody wants to get on and get on this Instagram live with me, go ahead and ask to be invited. I just here talking with anybody. So feel free to jump in. I'll accept, and we can just have a nice little chat if you want to talk. But the topic of today, for those that are joining, it's basically communication and how we can improve and strive for better communication between nurses and physicians, or PAs, physicians, and other clinicians. So we talked a little bit about SBAR. We talked about feeling engaged and feeling part of the medical team. And now let's talk about escalating concerns. And we talked a little bit about, okay, you've been part of rounds. You may have even question what was done on rounds. You may have even brought your concerns in the middle of rounds, and still you don't feel listened. That's where you as advocates, again, nurses, PAs, or anybody taking care at the bedside of the patient, you have to speak up. Everybody's always there for the best of the baby, and I can tell you, when we make medical decisions, it is always, always, always for the patient that we're making those medical decisions. And so if you feel strongly about something, we have to allow the culture of escalation. And that's where you may go to your nurse, your charge nurse. You may go to a nurse leader that you have within your unit and speak up. And really kind of mention, look, I am concerned that Dr. Ford may have chosen this type of treatment because, again, it didn't work in the past. And this is something that I feel very uncomfortable. Especially because if, sometimes, and I am the world's worst nurse. I shadowed the nurse a few days just to kind of learn, and what you guys do is amazing, because to me it's like magic. We write an order and then poof, the baby gets it. It's incredible. I know how you do it. So this is where if you have to give that medication or you have to do that intervention and you're really uncomfortable with it, then you really need to speak up. Because last thing you want to do is say, well, I guess Dr. Ford, he ordered it, so I'm just going to go ahead and robotically do it, even though I really think this is wrong. You do something, harm happens, a baby does poorly. And then obviously you're thinking to yourself, I really should have, spoken up. And again, no physician, no clinician is ever going to make a decision on purpose to hurt a baby. But you, as I mentioned before, being the second mom as at the bedside, you may have a little detail. You may know the patient. I mean, you do know the patient really well, many times more than us. We may know the physiology and the cellular and all this nerdy stuff, but you know the patient better than us. And it may be one of those situations where you say, you know what, last time this happened, you need to listen to me because, this time it may not go well. Okay? Having said that, I will, again, being fully transparent and honest, there are situations where ultimately we have to try something. We have to use our physiology, our nerdiness, and all this stuff to put it together. And if we come down with a decision and we really, really strongly believe that decision needs to happen, ultimately what's really hard about all this is that our signature goes on all the paperwork. And you stand in front of the court of law and they ask you, well, why did you not give this medication when this is something that most other physicians would do? You can't say, well, because so-and-so said it wasn't a good idea. So that's where it really gets tricky. But we're talking about really, really sort of difficult scenarios where you might be using a medication or you might be trying something that's a little bit, out of left field, there's not a lot of evidence for. I teach the trainees all the time, make sure you are practicing evidence-based medicine and standard practice of care before you do anything, because you want to make sure you protect yourself, but more importantly, you want to make sure that the babies are protected and you're not causing any harm, right? First, do no harm. So, but again, sometimes there are scenarios that are not typical. And in those cases, you may be doing something that's not standard, that there isn't evidence for, but there's really a good physiology and understanding. And in that case, again, you use your education to help everybody out, to really get everybody on the same page. Ultimately, your signature goes on every page, and so you may have to say, look, we really need to try this, and so on and so forth. But those situations should be really, really rare. Most times you really should have your medical team, including yourself, all on the same page before you push to the next thing. All right. So we talked about SBAR, we talked about, talking with physicians. Now let's actually jump and talk about some of the tricks when you're calling a physician. So it's 3 o'clock in the morning, you've got a situation, it could be that same situation we talked about with this 25-weeker who's with abdominal distension, that you may be concerned about neck or spontaneous perforation. So how do we communicate? We talked about the SBAR, right? When you call at 3 o'clock in the morning, you want to still keep that same SBAR. One of the things that we do as physicians, and letting you on a little trick here, is that when I get called at 3 o'clock in the morning and you get woken up, your mind's not completely there. I don't know if anybody, there are some physicians out there that can immediately wake up and within seconds know exactly everything that's going on, and they have a clear mind. Most are not like that, including myself. I need a few seconds to kind of gauge where I'm at, what's going on, which patient you're talking about. So one of the tricks that we do is actually just ask a little bit about, tell me a little bit about the baby and what are the vitals. What that's doing, it's basically allowing us, first of all, to wake up, but it also allows us to, think about what was our sign out for that room and that patient. As you're talking a little bit about the background, I may say, oh, that's right, this patient, I remember they signed out that I have to do, or I have to really watch out for A, B, and C, and this is that one patient. So using that situation and background really kind of helps us, find out where we're at, and therefore, move forward with understanding where we should go. The other thing that we do is at the same time, as we're listening to your situation, your SBAR, we're also now hypothesis generating. Hypothesis generation is basically where you're really just trying to think what could be going on. Before we even get to what am I going to do, usually if you call at 3 o'clock in the morning and you say, I've got this situation, the doctor says do A, B, and C like that within seconds, again, there are probably some people that can do it, but in general, don't listen to that. Go back and say, well, let me tell you a little bit more about the situation, because that quick response means probably they really haven't thought about it, fully. So we hear the situation, we hear the background. At the same time, we're generating a hypothesis. Okay, so the baby's having multiple DSATs, the abdomen is distended. This kid had a spontaneous perforation. Therefore, okay, we may be in a situation now where we've either developed neck, or if the baby had a drain, there's something going on with the drain. And then beyond your hypothesis, now you have to test your hypothesis. Just like if you're doing research, you have to now test it. And how do you do it? You test to see, okay, if I think it's sepsis, I need to go ahead and get a CBC, plus minus CRP. We won't discuss that today. That's there's some evidence to and not to get CRPs. Make sure if you want to look at culture or start your antibiotics. So you basically start now. I think this is hypothesis sepsis number 1, and so I'm going to be testing it out this way, and then I'm going to treat it this other way. And that's where we use basically, I don't want to get too nerdy into it, but we basically use different thresholds, which is our evaluation and our treatment threshold. If you say, the treatment is radiation, which we don't do in babies, but if you were to use your treatment as radiation, your treatment for radiation is way up here, and your evaluation is way down here. There's such a big gap. You're not going to get to that point. As opposed to if you really think that the baby's really, really, really sick and needs antibiotics, practically your evaluation and your treatment are right next to each other. If you don't think that the kid needs antibiotics, your treatment may be up here, in which case we do your screening. That's where we do our quick CBC, again, maybe plus minus a CRP, and we cross that evaluation threshold, but we're still not at the treatment threshold. Kid looks really sick, looks like septic shock. We basically do our treatment and our evaluation is in the threshold, is in the same plane. We treat it, we evaluate it at the same time, and so that's kind of how we play. We don't really think about these things. This is basically just happening through training. It's just happening in our our unconscious or conscious mind, but without us really thinking about treatment planes and thresholds and so on and so forth. So when you call, you do your SBAR, we do our hypothesis. That's where, again, we talked a little bit about this already earlier on, which is if you really, really do think that the patient needs to be seen, if there's really something going on and you're really concerned, that's where you use your buzzword. And you can't abuse it now, but that's where you use your buzzword or buzz phrase to say, I really need you at the bedside now. That is basically ringing that bell. It's picking up the red phone. It's telling us, okay, all right. They're really concerned about this. We really need to go ahead and go to the bedside. And that will be sort of a little bit of our bucket of water in the face, bucket of ice in the face. 3 o'clock in the morning, you're tired. You maybe, no, I really need you at the bedside. Okay, I'm getting up. I'll be right there. Okay, and you have to go. If your physician is again not getting it and maybe too sleepy or resisting, or again if they're not in-house, that's where you have to continue to emphasize, I am really concerned about this baby and I really need you now. So first phrase to get everybody up up and going is I really I'm concerned, I really need you at the bedside. Not happening, still there, okay, I need you at the bedside now. That's gonna be, again, that big alarm. If they're not going there, then you need to go to that physician supervisor. Obviously, if you were reaching out to a resident fellow that's not going, you go to the attending. If you're not going to the attending, then you go to your charge nurse to go ahead and escalate that to make sure they talk to the attending or somebody in administration, or somebody within administration, hospital administration that's on call that night, or you reach out to the physician supervisor. But I mean that really doesn't happen. It's just that would be an extremely rare and very unprofessional situation, and that again really shouldn't happen at all. Okay. I'm going to sort of end this live just going through a couple of other things. Oh no, sorry. Before we get to this part, I wanted to talk about some of the things that I, as a physician, wanted to tell the nurses about the don'ts, if you will. Okay, and this is not going to be negative. So hang in there. Stay with me. This is not going to be negative, but this is basically things that I think shouldn't be said from a nursing standpoint. Okay. Number one, I'm just a nurse. And that, I know when it comes out sometimes you may not even think about it. I may say, well, tell me, why do you think this, this kid, do you think this kid, can go on the, on the oscillator? Or do you think this kid, are you okay with us going down on the rate? And I do this even with our nutritionist. Sometimes when we're rounding with a nutritionist and, she's doing all the nutrition stuff, I even say, hey, we're going to go down to, what do you think of this? And obviously she laughs and all that, but I really want to make sure the whole team is included. And so same thing for the nurses. There shouldn't be. You guys are really smart. You've gotten through all the schooling and your boards and your tests and everything. You are taking care of really sick kids. You're in an intensive care unit. And when I was training and I was actually a medical student and I was thinking what I was going to do, one of the things that I loved is when I went into the NICU, the nurses were extremely smart, and in general, nurses are extremely smart. But in the ICU, you've got to be smart and on top of your game. I mean, every second, because things can go wrong. And so this is where you cannot sell yourself short. You really have to, if you don't know, at that moment, it's okay to say, I'm not really sure about the oscillator, but do you mind teaching me either now or maybe later? You can come back and teach me a little bit about, why you chose to put this baby on the oscillator as opposed to just leaving him there or her there and then changing all the settings. So this is, I'm just a nurse. No, you're not. You are the nurse. You are the nurse taking care of that baby, and you're really good. On the same token, though, make sure you stay reading. So sometimes, again, I'm all about education, and I hear, a ton of questions all the time. But you want to make sure that the questions that you're answering, it's not something that you can really go in a very simple question, Well, how do you treat apnea? Okay, that's, apnea prematurity. Well, that's something that really, you should know, and you can really Google or, WebMD or something very quickly to know that we treat that with caffeine. So this is, you want to make sure that, as you're asking your questions, that if you feel like, well, I'm not going to ask that question because that's probably something that I can, get on the internet in 3 seconds, then use the question asking for something that you cannot very quickly find on the internet, something that we can really teach you and educate you at that point, okay? And so, never be offended if you're a clinician, and I do this sometimes to say, hey, it's not a bad question, but I think you can really research that yourself, and let me give you a different teaching. You may be asking, okay, how do you treat it? Well, why don't you go in, and research a little bit more. Essentially, the treatment is with caffeine, but why is it that we treat it when we go for 5 days apnea free? Why the 5 days? Okay, and I can teach you and educate you on that versus just it's caffeine. Okay, so good. All right. The other thing, know your patient. One of the hardest things is hearing, well, I'm just covering, I don't really know the patient really well. What's hard is that we sometimes do that too. I mean, we as clinicians should not, but I hear it. I hear it sometimes from the trainees. I hear it every now and then where we say, well, I'm just covering. I actually don't know your patient. And what's really, really worse, and this goes for everybody, I'm not talking about now nurses, PAs, or everybody, is to never, ever, ever say this in front of the family, because that's not right. We do know the patients. We have gotten sign out. Nobody walks into the intensive care unit, sits down and takes care of the baby. We do know. Now, do you know every single detail? If you're not the primary, do you know every single detail? No, you may not know every single detail. If you're not on service for that patient and you just come in to do the night, you don't know the details, but you know that patient. So there should be no reason ever to say, I don't know this patient, right? You do know the patient. And if there's some detail you don't know, that's okay. You will learn it. You will, and that's where it's a team effort. You may know stuff about the patient from your side now that I don't know. A lot of the time, that's actually very true. And then I know stuff that we have signed out from our medical standpoint that you may not know. So it's important when you come in together as a team that you go ahead and put your heads together, because ultimately we really do know the patients, okay? I'm going to give you a quick hello to NICU Cheer. Thank you, Suit Sits, for joining. And again, if you like this and you like this format, go ahead and give me some hearts there. It really helps. And again, I will continue with the conversation of communication. And that leads us to the last part. The last part, I'm actually going to go ahead and talk about 4 difficult physician situations and what could you do in those type of situations. The one physician situation, or difficult physician situation, is the lazy doc, okay? That is the doctor that you call and you say, hey, I'm a little bit concerned about this kid because he's having some DSATs, and they say, okay, that's fine, just watch, call me if you need me. You call again and you say, he's having pressures are a little bit soft, he's still having more of these DSATs, and I'm getting a little bit more concerned. And they say, okay, yeah, no, I hear you, but this is the patient. Oh, he always does that, she always does that, don't worry about it. And it kind of propagates. Now, again, no one ever wants to be that physician. No one ever wants to be that clinician, but it can happen. So again, we've talked a little bit about this in the tricks of calling the clinician, but this is where you are the second mamas, and you've got to, or daddas, I'm sorry for the nurses there, for the male nurses. You are there to take care of the patient, and you are the best advocate aside from the parents, right? So that's where you really have to push. And we talked about using those little buzzwords or buzz sentences to say, I am concerned about the patient. I really need you at the bedside. Okay. And then escalating that, if that's not working, to say, I'm honestly really concerned. I need you now at the bedside, and just changing that intonation. And that may be hard. You may be a new nurse, a new PA, you've got a week or two, starting in the NICU. It's hard to feel like you could do that. And phone a friend, get one of the, your senior nurses to help you with that. If you feel really uncomfortable, or your charge nurse, go to your charge nurse if you're really concerned about the physician or the clinician not responding to your concerns, okay? All right, the second situation is the unfortunate condescending jerk clinician. We hope never to be in those situations. You really don't want to be that guy or that gal. But again, it happens. How do you deal with somebody who is condescending? That you call and you say, I'm having these DSATs, and I'm really concerned, and you have that clinician, basically say, that's apnea prematurity. Why haven't you haven't read about this? This is a preemie baby. Of course, they're supposed to have this. Why are you calling me at 2 o'clock in the morning? Please don't do this again. That's horrible. And I hope, again, no one ever does that. But if it happens, that's really where you have to take a deep breath, because this is not you. And that person is not saying this because of you, of who you are and your background and your personality and all this. No, this is just somebody who, again, not ever an excuse, but who is going through a moment. Or if the personality is like that, then you have to spin it. And that's where you really have to take a deep breath to say, no, I understand that, this baby is premature and having these events, but this is something new. And it's okay to say, look, I'm a new nurse, and so please, would you mind, teaching me, educate me, tell me why this is actually normal as compared to some of the other kid, because last week there was somebody doing the same and he has septic shock. So I would like to know why the situation may be different. And that can really kind of help a little bit. And you want to do it in a calm voice. Of course, you never ever want to escalate your anxiety, because it can be really scary. So you take a deep breath and very gently say, I just need to be educated as to why another child who's had this before, the other physicians responded very quickly, and I just wanted to understand why maybe you are considering this just as a normal apnea prematurity when others have considered it more differently. And that should at least wake up the clinician to, if anything, realize, okay, why is it my other partners are treating this differently? Why am I not that concerned? And hopefully that is enough to be able to indicate to that person that you can't be talking like that, and just remain calm. That's the main thing. Obviously, if they're doing something that's very unprofessional, inappropriate, that's where you talk to your charge nurse. We talked about escalating this if you need to. Okay, let's see. The next scenario will be nervous Nelly physician or nervous Nelly practitioner. So this is that flip-flopper clinician, that doctor who will basically envelop themselves in all the clinical theories. And we talked about hypothesis generating just a little bit ago. Well, you need to be clear in generating your hypothesis and following it. This is not research where you're generating 10 hypotheses and trying to test it and trying to solve gravity. Basically, these are the clinicians that will start saying, well, it could be necrotizing enterocolitis, because they got this, but then also the baby has pulmonary hemorrhage, and no, it could be, and they went to surgery. And you need to know what you need to do, because obviously the patient may be getting sicker. And so that's where you can use something like, okay, I understand. So you talked a little bit about pulmonary hemorrhage and necrotizing enterocolitis. Let's look at this scenario together. So why were you thinking necrotizing enterocolitis? Well, because, okay, don't you think we should really evaluate that? Why don't we consider that as a possibility? Is that your first thought? Is that really what you're really concerned about? And then if so, then let's go ahead and evaluate that first. And what else are you concerned about? Pulmonary hemorrhage. Okay, do you think the likelihood of necrotizing enterocolitis is bigger than pulmonary hemorrhage? Yes, I do. Why don't we start with that and and sort of kind of walk with that person and be able to help them through some of the decisions. And again, this comes with time. When I first started out as an attending, I'm sure I was a little bit like that too, because it's scary when you're trying to make a decision for the first time. It's really on you. It can be really scary. So that's where, especially a lot of the senior nurses and PAs, can be really helpful for us as clinicians to say, hey, look, in these situations, what they've usually done is just to make sure that this is not something going on. We've done a chest x-ray and a KUB, and we get some lab work. What do you think about that? And so you can propose. This goes back to the recommendation part of your SBAR. You can propose, how can we think about this together, and how can we best deal with the patient right now as you are trying to develop your hypothesis, and then moving on to going ahead and actually carrying out that plan to treat the patient. So this is basically a way to be able to help those flip-floppers, those heavy thinkers, and they may be really smart. They may be thinking a whole lot about all the hypotheses, and they're right. But in the intensive care unit, sometimes you have to act. It's really important to think of your hypothesis, and you need to act on those ones that are sick, especially. I want to stop again. I've seen a couple of people join, and thank you so much. Idita 586 joined, and my good friend Perinatal Care MD. Thank you so much for joining and watching. We're basically talking about, for those that just joined, we're talking about communication between nurses and doctors and how we can really improve, because obviously this is what it's all about. We're here to take care of patients. Whether, for my good friend, by the way, Perinatal Care MD, you have to watch his videos. He's on Instagram. He is great. He's obviously a perinatologist, and he has some great videos on gestation and then, carrying into the babies as well. So, please watch his stuff. He's awesome. And again, we are all here taking care of patients, whether they're, itty bitty tiny 400 grammars or 400 pound ladies like my friend takes care of sometimes. So let's talk about the last scenario, and these are your brainiac doctors. It goes a little bit hand in hand to what we talked about with Nervous Nelly, but instead of Nervous Nelly being kind of all over the place, the brainiac doctor is extremely smart, a great heavy thinker. But again, he or she gets stuck with the thinking part. And that's where, again, as a nurse or PA, you help them through that. You basically have to get the information out, digest it, and then bring it back to say, okay, it sounds like your hypothesis is this. It sounds like you think this is what's going on. And I've seen these scenarios. We do A, B, and C. And that's what happens sometimes. You have these, again, very, very smart clinicians, nurse practitioners, doctors who, on trying to make a decision, are thinking about all the scenarios and all the possibilities. And again, it's great that you're able to do that. But when we're dealing with a very sick baby, a very sick patient, and you really have to act on that, that's where, again, as a nurse PA, you go back. I'm hearing that you may be concerned about some weird organic acidemia. If you have some time, you allow that person to teach you. Hey, you keep on mentioning this thing about something genetic. In a couple of minutes, can you just kind of briefly fill me in as to what you're thinking, why you're thinking something genetic in this case? Educate me. And I know we really need to get back to treating the patient. So, hey, we probably have a minute or two. Educate me on what you're thinking about this weird genetic stuff. And then let's go ahead and act on how we can evaluate what you're thinking of. And that's how we have to do it in the intensive care unit. Because again, if you have time, great. You're doing on rounds, learn all you want. But when you're dealing with a sick patient as a nurse, as a PA, if you have the time, allow them to educate you a little bit. We're all educators. We love doing what we're doing. And in academia, that's why we go into academia for sure. But when it comes to sick patients, you have to act. And so help that clinician basically, focus. And it's okay. And again, you're basically just trying to, get them to your plan by saying, we got a minute or two to make a decision, but I'd love to learn from that. So, hey, in 1 minute, tell me a little bit what's been going on. And now let's go ahead and focus on evaluating what do you need, what labs do you need, and let's go ahead and do the treatment for what you think is going on. The last thing what you don't want to do is say, look, you know what? I don't care. Just tell me what to do. You may be feeling that way as a nurse and as a PA, but obviously it doesn't, come out very well when you say something like that. So that may be just a little trick that you can use to move on to say, we got a minute or two. Let's get this done. So those are the sort of the 4 scenarios, difficult scenarios with any clinician. And so, if there's any questions, I'd be happy to go ahead. We have a little time. We've gone through communication with SBAR. We've gone through talking and being included and feeling included on rounds, escalating your concerns, speaking up, bringing it to the crowd. If you are, somebody calling somebody in the middle of the night, some of the tricks that we clinicians do to kind of wake up, perk up before we actually make a decision. And then ultimately, we talked a little bit about the don'ts of nurses, which is, just saying I'm just a nurse or PA, I'm just a PA, because you're not just you are the. And you guys are amazing and you guys are really smart. So again, emphasizing that point, and then just kind of closed on the 4 difficult situations. So I'm happy to, if there's any questions, please feel free to go ahead and put them on, and I'll wait, a few seconds. And if you have any actual scenarios where you've had you had difficulty with a clinician, or if you're a clinician and you thought, any advice, something you can give, or even a difficult situation with a nurse and how we can address it, I'm happy to do that. So let's wait a few seconds. All right. Well, again, I really want to thank everybody for watching and tuning in, and it was really nice to see some of the people I know, and then some new people join as well. Thank you so much for watching this live. Really appreciate it. I'll be doing this. Hopefully, I can try and get live in on a weekly basis. That's always my goal. There are going to be some really cool lives that you'll see on my Instagram. Stay tuned. I'm going to be doing a couple of lives with some really, really good people that you guys will recognize. And I'm so excited to do that. Can't talk about that just yet, but you'll see that pop up on my stories and my posts, especially because we are celebrating, NICU Awareness Month. So I got some cool stuff coming up. And again, thank you for everything. On a daily basis, I always try and educate. I am posting the NICU Parental Guide on a daily basis, where we basically just have the nurses give some advice to the parents, have parents give some advice to the parents, and then also I'm educating on certain topics. If you haven't done so too, I have several videos on my YouTube channel. You can search for the NICUDoc, and we cover topics anywhere from, for trainees, how do you blow away the medical team? How do you, perform well on rounds? We have stuff for parents and talking about, some tips either from other parents or also from myself. I have videos on coronavirus as well. And last week, I actually launched my webpage, so you can go to www.thenicudoc.com, and I will be updating stuff on a weekly basis. And you can read a little bit about our method that we developed with 2 other doctors called SALSA, which is actually given surfactant through an LMA. This is something new, and that's something that I've been traveling around the country before COVID, around the world actually, teaching with my other 2 colleagues on this topic. So thanks again for watching. Really appreciate it. Thank you for all the likes, and you guys are awesome. And again, for those that are watching this, after the live, hope you love it. If you, please like it, share it. And if you want to go ahead and add some extra, comments, or you want me to do a live on other topics, please do. All right. before we go, I think my good friend Prenatal Care MD says, everyone know a lot about pregnancy, but few people know what to expect if their baby ends up in the NICU. Thank you so much. I really appreciate it. I think it's great that we have this huge partnership between, you know, the OBGYNs, the MFM doctors, so the maternal fetal medicine doctors such as Perinatal Care MD. Again, if you haven't watched it, please go see his Instagram. He's got some great videos and informational stuff. And then us. It really is a continuum, all the way from when the fetus is born, is formed, all the way through the NICU and through life as a child. It's all a continuum. And this is why I always say it takes a village to take care of a baby, and it starts with your OBGYNs, MFM. So thank you for that comment. Thank you, everybody. Have a great evening, and we'll see you with the next one. Have a good night.